Hi everyone. I'm Dr. Saif. I am an MD biochemistry as well. So my field of interest lies actually in emerging biomarkers, LIS, and of course nutrition. So I'm just going to continue what Dr. Sai already started. So he got you warmed up with how the legal aspects are there, which we need to always keep in mind. He also discussed a couple of test panels, and my segment is basically going to cover CRP and inflammation, thyroid and micronutrients, and a small case study. Okay. So you all have probably heard about this CRP, right? Currently, it's like the hot topic which many people are talking about. But the problem is that validated information is not currently available for this in the books, especially. So many of us don't know what to trust. There's a lot of research around it. So, what is CRP? What do you think it is, CRP? It's just a protein, actually. And you, most of you might know that proteins are synthesized by the liver. Okay. So, slowly starting to build up a concept of CRP, and this is where we start. So, first thing we know is it is a protein, and the second thing we know is it is produced by the liver. Okay. The next question is, okay, we understand there is this hype of CRP, but why is this hype so much? Like, is there any truth to it? And definitely there's a truth to it. And that is because CRP is actually, it has been proven to show systemic inflammation. And it is showing inflammation in a way that other parameters are unable to show. And that's what makes it really impressive. And systemic inflammation, if you are more into the clinical stuff, you will know that it's a hard thing to catch. And there's like so much difficulty you face with the systemic inflammation, not only clinically, but also in your weight loss or your bodybuilding or whatever you're into. So this is like the basic of what we understood about CRP. So let's just go on to a couple of optimal ranges or the values of CRP which matter. So CRP, if it is less than 1 milligrams per deciliter, that means it is pretty much normal and you don't have to change anything. So you don't have to do any specific intervention to work on reducing the inflammation. The two ranges which I am really concerned about as a clinician is the gray zone and the red flag zone. So nearing the ending of his session, Dr. Sai told you about the red flag zone, right? So this red flag zone for CRP is more than 3. And if you see this kind of a red flag zone in the client's report, then you need to refer them immediately to the physician. It's a really serious thing. The place where we can actually do something or try to understand deeper into why this is happening is the gray zone. And we are going to talk a bit about the gray zone as well. But before that, I just want to tell you there is a very basic kind of error which we can do in CRP analysis. Now, many of the people don't know this, and that is that in cases of really high stress. Now, when I talk about really high stress, an example I could give is overtraining or lifting really heavy weights. So this can be classified as high stress. In this situation, the liver actually produces something called IL-6. You might have heard about this IL-6. It is actually a cytokine. And cytokines are nothing but they are inflammatory markers. They are physiologically produced by the body to basically reduce inflammation. So IL-6 is leading to synthesis of, sorry, high stress is leading to synthesis of IL-6. And IL-6 is going to actually trigger the synthesis of CRP. Okay. So this is completely physiological, which means it's completely normal. It's the body's response to reduce the inflammation, which healthy inflammation, which can occur due to overtraining or maybe lifting heavy weights. The mistake which people can fall into is if they test their CRP level, even 24 hours after this heavy training session, they will see a falsely elevated CRP level. And as you can think of it, it's really a big problem. So recommendations based on the literature are to rest around 48 hours if you're a person who overtrains a lot to get your CRP done. Okay, so now that is out of the way. If this is covered and the CRP is taken properly, the next thing is, which I was talking about, is the gray zone. So I told you that the gray zone is between 1 to 3 milligrams per deciliter. Now, the what the gray zone actually signifies is chronic low-grade inflammation. Now, chronic low-grade inflammation can be due to a lot of causes, and we can't really go on to the various causes. But sometimes it can be due to something which is wrong with their diet or their sleep or their training. So in this case, what you can do is, based on the literature, what they are saying is you can give omega 3s, you can audit the sleep, basically improve their sleep hygiene to reduce their overall stress levels, and even try out fiber, increasing the fiber intake overall. And along with this, you'll have to get them connected with a physician or a doctor, because ideally we'll have to do multiple more tests to figure out why they are even in the gray zone. Okay. But the good news is you can do something about this, unlike the critical zone. Okay. So now we know what is CRP. We know a couple of different zones of CRP. Now I just want to take your attention to a study which is talking about the relationship between CRP and albumin. Okay, this seems like an interesting study, but you might not understand the value of the study. This study has actually said that there is relationship between CRP and albumin. Now, this this is a big thing. This is why is this a big thing? Any idea if you think to yourself? So the reason this is a big thing is because albumin is a very important protein in our body. And if you have read about albumin, it is one of the major transport proteins. And what does it transport? It transports hormones, it transports vitamins, couple of minerals. So it is one of the major transport proteins for thyroid, for different kind of hormones. So if the CRP goes up, the albumin has been found to go down based on this study, and it's a good study. So if there is inflammation and albumin is going down, that means that many of your parameters, which can be some of the micronutrients, it can be some of your hormones, and we don't know what else, that can be affected in your actual report. So this is kind of a new paradigm where we have to connect multiple concepts to see that the report might not be 100% right. Okay, so this is an interesting point which you can actually learn about CRP. Then a couple of more things which you can talk about CRP is, if CRP is raised along with something called ferritin, and we haven't covered ferritin much because then this would become a more advanced kind of lecture. If both of these are raised, then the problem is actually confirmed inflammation. There is no way that these two are raised and there is no serious inflammation. Okay, so this is one quick tip which you can follow. Another one, if CRP is raised and HbA1c is raised. So I'm hoping, assuming you know what HbA1c is. I think Dr. Sai covered this, like the critical value of HbA1c. If both of these are raised, it's been found that many of the people with these levels are having metabolic syndrome. So metabolic syndrome is another topic which is catching a lot of limelight today, especially in diet and nutrition, because it is not diabetes, it is not like a very high kind of a high risk stage, but the risk of cardiovascular problems is increasing in metabolic syndrome. And if you want to read more about the metabolic syndrome, you can check out the NCEP ATP3 guidelines, and you can get some clarity about this. Basically, what this is there is some kind of excessive fat, and that is leading to problem with the metabolism. Okay, as a very basic thing. And these two things can be very well understood or found out by measuring the CRP and a couple of different markers. Okay, so I don't want to go more into CRP. I think that is sufficient at this level. And this is the takeaway you can go with regarding the CRP. Okay, now let's move on to the next set of tests. This is the thyroid function tests. Thyroid function tests are another very discussed kind of topic, and there are many nuances to this. Here I have shared basically a clinically relevant reference range of total T3, total T4, TSH, free T3, and free T4. Now, for those of you who might not know about what these tests actually signify, they are actually the thyroid hormones which are secreted by the thyroid glands, and they help in various different processes in the body. And the most important process they help in is the BMR. And hence, we are talking about this since this is about nutrition coaches. So, BMR, as you know, is the basal metabolic rate. It has been found that higher levels tend to increase the BMR, while the lower levels tend to decrease the BMR. Okay. So now when we are interpreting thyroid function tests, how do we know if a person is hypothyroid or hyperthyroid? So hypothyroid would mean their thyroid gland is not functioning that well, and hyperthyroid would mean it's over functioning. Normally, this is the reference range which needs to be followed by your thyroid gland, but if it doesn't, then these are the disease states. So hyperthyroid basically presents with decreased TSH and increased T4 and T3 levels. And these T4 and T3 are basically named because of their chemical structure, the positioning and the number of iodine atoms, if you will. They are basically thyroxine. Thyroxine is the thyroid hormone, major thyroid hormone. So this will signify hyperthyroid state. If TSH is more than the normal, which is this normal, and the T4 and the T3 are less, it signifies hypothyroid situation. Okay. So now hyperthyroid, as I told you, is directly related to the BMR, right? So hyperthyroid would boost your BMR to really extreme levels. So there might be severe like weight loss kind of a situation. And hypothyroid can actually lead to weight gain situation. And as you can think, this can be valuable if you're into nutrition coaching. Now, based on a couple of studies recently, especially in 2023, the reference ranges which I showed you here are the clinical reference ranges. These are the reference ranges which you will find in almost any lab report. These are the reference ranges which clinicians follow, doctors follow. Okay. But with the new studies, current studies, what we are seeing that there is something called a functional optimum. Okay. So the clinical normal is what I just showed you. The functional optimal is something based on this study, which is the optimal health ranges of thyroid function defined by risk of cardiovascular disease and mortality. What they found out is there's a certain level where which the people were having, and based on that, they were less prone to getting cardiovascular symptoms. And of course, this was a meta-analysis, and further studies are definitely required. But what you can take away from this is if this functional optimal is where your clients are residing in, it means their fat loss journey and their overall muscle growth might be much, it will be optimal. That's why it's called functional optimal. Okay. Now, the next concept in the thyroid function test I want to talk about is the thyroid hormone pathway. And you all might have already seen this. This is the like the basic pathway which we talk about, and that is the pituitary gland secretes TSH, which is the thyroid stimulating hormone, and that leads to synthesis of T4, which we talked about, thyroxine. And T4 is specifically the storage form of thyroid. And T4 can come out of the thyroid gland and it can be bound to albumin or it can be free, which is the free T4. And this free T4, which is also a less form, so there's total T4 and there is free T4. So all of both of these are present in the blood. The free T4 specifically goes to a conversion pathway. This conversion pathway is critical because it is going to synthesize free T3. Okay, so it's just going to switch itself to free T3, which is going to be the active hormone. And this is going to do all the beneficial effects of thyroid hormone, which is these are a couple of effects like energy production, fat utilization, muscle repair, and mental clarity. Of course, there are many more functions which are still being researched, but these are a couple of ones which are relevant to this session. In certain cases where there is really high stress conditions can lead to cortisol elevation, as you might know. What is found is there's something called reverse T3 formation. Reverse T3 is completely the opposite of free T3, which is helping with the effect of thyroid hormones. Reverse T3 is blocking the effects. So this will lead to frozen metabolism, fat loss, plateau, exhaustion, even though the labs might appear normal. So how is this relevant? Okay. So you will see maybe in a person's report that the T4 is normal and even the T3 is completely normal, but they are having a really hard time with maybe fat loss. So one reason could be due to the high stress, due to various reasons, and inflammation can be one of the reasons. There is excessive RT3 formation, and this is leading to the determinal effects, which are leading to decreased thyroid hormone action. So even though the labs are completely normal, the person will not have a proper fat loss journey. One more thing here is you have a client who is being treated for thyroid abnormality, maybe a hypothyroidism or hyperthyroidism. What you will see maybe is the TSH is elevated and the T4 is also elevated. So ideally, if a person is having, say, hypothyroidism and they are being given thyroid supplementations, T4 will go up, but the TSH is what we call a lagging parameter, which means it takes a couple of weeks to months for it to actually stabilize. So this is relevant because some people just start on thyroid medication and they get their thyroid function test done maybe 1 or 2 weeks later, and they are expecting that the treatment is working well and my reports should reflect that. But that is not the case. As you can see, this TSH takes some time, maybe even 8 weeks, 8 to 12 weeks also in some cases, to come to a stable level. That's why the thyroid hormone treatments are prolonged treatments. They are not something which we can end in a couple of days or weeks. Okay. So this is what I wanted to talk about thyroid. So you understood the different reference ranges and you understood a couple of caveats which you can keep in mind are valuable for you when you're tweaking the fat loss protocols. Next, I want to talk about micronutrients. So I'm not going through all the micronutrients. There are so many micronutrients, and this is not that kind of a webinar. So we are going to talk about the three major ones which are really relevant for you, because vitamin D, vitamin B12, homocysteine are important in the sense they are showing really good results, especially in helping with the soft tissue injuries, the brain fog, and poor recovery. Okay, let's talk about vitamin D. So here I have mentioned the optimal range as 40 to 60. You will not see this range in a lab report because this is a range which the newer researches related to the functional medicine are showing. The normal range you will see in a report is probably less than 30 is insufficiency and less than 20 would be deficiency. But this is a problem because even if a person, say, has 30 nanograms per deciliter as his vitamin D report, they might face all the vitamin D deficiency symptoms like soft tissue injuries, repeated illnesses, or poor mood. So as a coach, you can really pinpoint this quickly and get them started on supplementation and sun exposure and try to get their levels between 40 to 60. Now, vitamin B12 is, it's been shown to lead deficiencies, being shown to lead to brain fog, poor recovery. And vitamin B12 is a vitamin which is the deficiency is being found mostly in vegans or vegetarians and ages of 50 plus. Okay, because after the age of 50, it is found that the absorption of vitamin B12 actually goes down. So for these reasons, I found this interesting point where they have actually kept the lower limit of vitamin B12 as 500 picograms per ml in Japan. But if you see in India, mostly it will be maybe 200 to 900 or 200 to 800, something like that. But the optimal range, which I want to recommend here, is 400 to 700 picograms per ml. And if you follow this, I think it would be great because people who are even in the 250 or 300 picograms per ml ranges are having these problems with brain fog, poor recovery. Okay, then finally, I wanted to talk about homocysteine. And this is also an upcoming one because what we are seeing in the past decade, specifically in the past 5 years, is very young adults are getting heart attacks and they are, even though they have a good diet, they have a good training regime or anything. Homocysteine started emerging because we were not having a strong cardiovascular disorder predictor. What we were working with mostly was LDL or lipid profile. We were, for acute situations, we were checking out troponin or something like that. Homocysteine, what it did is that it is able to detect beforehand if the person is going into the cardiovascular risk. So the optimal range is less than 10, and it is elevated if it is 10 to 15. And another caveat of homocysteine is in one go, you can assess the the current state of vitamin B6, vitamin B12, and folate. So you can assess the status of three different vitamins. And you might ask, how is this possible? It's because homocysteine is is one of the analyte which occurs in the metabolic pathways of all these. And if this is deranged, then most likely one of these is deranged. And of course, if it's deranged, you might have to get these tested as well and go deeper into this issue. Okay, the next thing I wanted to talk about in micronutrients is the role of magnesium in vitamin D activation. So, what these studies have shown is that magnesium is responsible for vitamin D activation. If a person has a deficiency in vitamin D, okay, and we have seen the reference ranges, right? with the old paradigm, we used to just treat them, right? This is the old paradigm. You get vitamin D deficiency and you treat the person. The new paradigm suggests that if this is the case, then just check serum magnesium levels. If these are normal, then you can directly go to treatment. And if these are not normal, then it is recommended that you actually treat the magnesium first. You start giving them magnesium supplementation, and then you can go for vitamin D supplementation. Now, this is because of this study, which has showed that magnesium is responsible for vitamin D activation. Okay, so this is a valuable point which you can take away from this. Now, as we are coming to the end of the micronutrient part, there is something which I can connect with the micronutrients and the case which we are going to discuss next. So, this is a study where vitamin B12 deficiency was related to metformin use. Okay. So, but before we get into this understanding, this new concept, let's just first understand what is diabetes and how it's diagnosed. Now, I don't want to explain to you what exactly is diabetes from scratch because you already probably know that. So type 2 diabetes mellitus, according to the ADA, which is it's the American Association which determines the various guidelines for coming to the diagnosis of diabetes. They have said that the fasting plasma glucose, if it is more than 126 milligrams per deciliter, that qualifies as diabetes. And postprandial glucose, if it is more than 200 milligrams per deciliter, that also qualifies as diabetes. And the thing which you already probably know is HbA1c of more than 6.5% qualifies as diabetes. And the reference for this is this Medscape article on the diagnostic criteria for diabetes. So the case which here I wanted to talk about is a diabetic person is one of your clients. And the issue here is he's on a list of medications, okay? And the list of medications includes metformin. It includes metformin, and he's also having a problem with fat loss. It feels like he's in a plateau of some sort, and he's having neuropathy. Specifically, he's having like a tingling sensation in his hands or his legs. So, what do you think you can understand from this? So this is what I want you to understand from this. Diabetes is basically a disorder where the patients battle in five fronts. Okay. And these five fronts, no need to be completely overwhelmed with this. It is all interlinked in a way. So the first front is insulin resistance, and that is actually why a person gets diabetes in the first place. So insulin is, if you don't know, it's a hormone which allows for the pushing of glucose into your cells or tissues. And glucose cannot do anything if it's just in your blood. It has to go into your cells or tissues to actually do something. And if there's insulin resistance or there's lack of insulin altogether, then there can be diabetes. Okay. And diabetes basically means, simply put, there's increased glucose in your serum. There's a lot of glucose in your serum. And that is how we saw the diagnosis is also done, right? So that is one front where they battle with. The next front is they battle with fatty liver, or they can battle with fatty liver. Like Dr. Sai gave a case on fatty liver, right? That person with the fatty liver can also have diabetes, and he's very likely to have diabetes as well, because if there is insulin resistance, that can lead to increased triglyceride levels as well, and increased triglyceride levels can also create a strain on your liver, and there can be increased liver enzymes. So that is one front they battle with. Another front they battle with is central obesity. Now, with diabetes, the overall metabolism can also go down because insulin is a major hormone for metabolism. And there will be central obesity. The fat accumulation can occur. And what has been found is that the fat is not just an inactive kind of yellow stuff which we imagine. It is live in a way. It secretes different kinds of adipokines, even inflammatory markers. So if there is excessive central obesity, then they deal with inflammation, they deal with deranged kind of hormonal activities and all. So the lipid panel will also most likely get affected in a diabetic patient. And there can be systemic inflammation in diabetes. And this is associated also with oxidative stress because there's so much glucose in your blood, and the body is unable to push it into cells or tissues. What happens is the glucose starts finding other pathways, and it can go to something called the polyol pathway. And this polyol pathway has been found to actually be the major reason for the lens issues, the kidney issues, the nerve issues which the diabetic patients are facing. Because this leads to synthesis of something called sorbitol and then fructose, and these get accumulated in the various tissues and they can lead to oxidative stress and systemic inflammation. So now we know that these are all the things they are battling with. We have to somehow figure out how we can help these patients along those guidelines. So the main thing I would recommend here is that you need to first of all work with the doctor in this case, and you need to make sure their medication is properly optimized. Okay, and then you need to think about metformin as well. What we were actually discussing is metformin and its association with the B12 deficiency. So what metformin does is metformin can block a calcium dependent membrane receptor, which is responsible for B12 absorption. And if this happens, the B12 is not absorbed. And that can lead to all the symptoms related to B12. And if you caught it, that's good. You can actually start them on a supplementation of B12. But if not, then they'll face all these circumstances. Okay. So I just want to now come to the conclusion of this. The two standards which we have come across in this session is a clinical normal and a functional optimal. So clinical normal is what we see in the lab reports, and this is very important, but from a clinical perspective. But from a coaching perspective and fat loss perspective, the functional optimal is what you can actually think about and go deeper into. And finally, a coach's blood framework, which I wanted to give you is like these are the 7 things which you can think about related to the reports. One is read CRP and understand their play to. Now, this is not just for CRP. All the tests which we have discussed in this session, you can read it and you can correlate with whatever examples we gave. The second is hold the functional optimal standard. And this functional optimal standard is a new paradigm for us all. So if we start researching more with that, it will be helpful for fat loss, especially. Catch micronutrient deficiencies, and because these are missed. Know metformin depletes vitamin B12. Know where your authority begins, like Dr. Said told about the various legal aspects, right? So legal aspects, and also it's more professional to not treat or undermine a report, which can be a problem for the person later on. And don't always trust the labs, as we have seen so many examples in this session where the labs might appear normal, but there's a deeper underlying metabolic problem. And of course, get to work. And the reference ranges on lab reports are mainly for sick patients. They are not for athletes, which you might be actually training. And we found out that functional optimal is not clinical normal. And another small kind of tip you can take is retesting after 8 to 12 weeks of any intervention for any lab test is a really good idea. Now, this is like the end of my session, but I want to give you something. It's basically a library of different biomarkers. I'll just share my screen here. So this is a library curated by doctors, so you can rely on it. It is a library of different biochemistry parameters, various other tests, and this library is continuously being updated by doctors, where you can just click on any kind of test. You can read the description, the reference ranges, and the critical values. So for example, we're talking about CRP. You can just go and check out CRP. As you can see, 2 things here, CRP and high sensitivity CRP. You can just go read about it, get the reference ranges clinically, of course. These don't have functional optimal ranges, and the critical values. And this can be a quick resource for you where you can figure out what this means, what the tests mean. Okay, so that's it from my side. Would Dr. Sai want to take this?
Dr. Sai, please unmute yourself first.
Yes, 1 second. I will share the screen. So thank you all for attending this webinar. I hope you got great value from it. So I want to just give a brief about something like we are trying to build at NCA. So this is a course called Metabolic Code Fellowship for coaches, where the clinical science will meet your coaching precision, and it deals with clinical nutrition and biochemistry and more complex cases that we are going to deal. So this is just a snippet. The webinar is just a snippet of what we are going to deal at this course, and information regarding that will come in upcoming weeks. Whatever doubts will be answered in those coming weeks. And now we'll go for the Q&A. So let's see the chat box. Siddhanji, can you moderate this Q&A?
So go back to the first question from Akash Yadav. Can't we control high lipid profile without taking statins?
second, I'll stop share. Yeah. So yes, we can control it, but in early stages of fatty liver, यहाँ जो thing that comes is you need to work with a physician where he can identify whether the liver has fibrosis. This concept is very important because अगर liver fibrosis हुआ, the fibrosis means the liver's cell is beyond capacity to get its function back. Liver has this remarkable ability to get its lost function. It's the only organ that can do in terms of all the organs in our body. So अगर fibrosis set हुआ, whatever percentage it might be, and that we only can identify on a fibroscan or advanced scans. अगर वो set in हो गया तो it might be difficult without statin therapy, but अगर grade 3 मतलब more than 60% of your liver is having fat inside the body, that is grade 3. Agar they don't have fibrosis in that level, very high level, you can do it with normal nutritional and exercise interventions. That can be definitely done without statins. But once this fibrosis has set in and very high levels of lipids are there, that's where you need to put your boundary and work with a physician. I hope it answered.
All right. So the next question is from Amol. Does imbalance of thyroid hormones cause nerve pain and neuropathic pain in feet? And can this be addressed via dietary changes over time?
Yeah, so if I can take this question, thyroid hormones can actually lead to that, but it's kind of rare because you will probably find it in other symptoms as well, not just nerve pains. For example, a person can have myxedema, where the person is having hypothyroid, severe hypothyroid situation, and that can lead to neuropathic pain. But it's not a direct correlation, it's like a small, rare finding. What you need to focus on is diabetes, that is the main thing. And also, in certain cases, other micronutrient deficiencies and alcohol. Alcohol can lead to neuropathic pain sometimes.
All right, thank you. Next question. Can you reverse a grade 3 fatty liver in a diabetic person who is also obese? I'm talking about reversing with the help of medications or exercise.
So like I'll take this one. So see, abhi grade 3 ho gaya, तो it is like you already know it's more than 60% of your fat, fat in the liver. And now he also has diabetes, so he must be on some or the other kind of medication, probably 2 or 3 types of medication, not just metformin. तो वो metformin हो सकता है, GLP-1 agonist हो सकता है, like semaglutide or Ozempic kind of things. And in these patients, first you need to assess the severity of fibrosis again. ठीक है, because that will help you plan your exercise intervention in a good manner, because exercise intervention plus a significant 10% weight loss will definitely help improve their insulin resistance and thereby improving their percentage of liver that is storing the fat. So weight loss through exercise intervention and dietary intervention is single most powerful tool you can employ, and that's where the coach's role is very critical in this kind of situations. Understanding the medications, like how Dr. Saif has discussed regarding the micronutrient deficiencies and stuff that can arise with the medication interactions in all, like metformin, that you need to understand and then intervene.
Dr. Sai, can you also clarify if reversal is the correct term to use, or is it management?
Yeah. So reversal of fatty liver might be possible, but not maybe the diabetes, because diabetes will be in remission. There is this word like remission that is there for any kind of disease or a disorder. You can only use this remission word. There is no kind of reversal. Fatty liver can be reversible, as I said before, depending on the fibrosis. So that's where I can put the judgment.
All right, thank you. Next question is from Anmol. Can mildly elevated levels of TSH around 6, while T3 and T4 are normal, also be treated through nutritional intervention? If yes, what are the protocols we should keep in mind? Dr. Saif?
Okay, if I can take this. So this is actually the classical case of subclinical, what we call hypothyroidism. So this is currently like a lot of talk is going on, and what he asked is the nutritional intervention is definitely the approach we want to go with in this case. How you can do it is, a couple of tips you can take is, there's something called goitrogens, and you might have studied about this, like this cauliflower, cabbage, stuff like that. There's an entire list. So one thing you can do is avoid that. The other thing is protein intake. If you improve your protein intake, that is going to help with this. And the sleep